So, gone to my talk. But no conflicts of interest to declare. I'm going to try and keep to the 15 minutes covering this agenda. First, talk about digital technology, diabetes care, focus a bit more on the role of digital technology for diabetes in Ramadan. A bit of evidence, not much there. And then talk about telehealth and future applications, including AI adoption. So, digital technology in diabetes care. So, if I get back to the technology itself, we know that the Gartner cycle of technology, where Gartner is a recognized world's most respected organization talking about objective insights in technology-focused data and best practices, where they also provide the data for research on technology and related industries. So how technologies evolve from initial hype to actual mainstream adoption. So we also know there is a graphical representation with regards to the maturity of adoption and social impact of emerging technologies over time. So the key takeaways from this graph is to help us maneuver, right, the framework for navigating the complex world of technological innovation. So if you look into the hype cycle for emerging technologies in 2025, the core themes are as follows: autonomous businesses, where we use AI, machine learning, interconnected systems to operate with minimal human intervention; hypermachineity, which refers to physiology of building increasingly autonomous and intelligent systems that can outperform human-machine processes in speed, accuracy, and consistency; augmented humanity, where we use enhance human potential by integrating technology like AI, AR, robotics, and wearables, as well as techno-societal fragility, where we actually explore inherent vulnerabilities and risks within the society that arise from extensive reliance on interconnected technological systems. So these actually present both opportunities and challenges for our healthcare. So if you look at it, generative AI has gone into almost mainstream now, but it has started even like from last year. So there are quite a lot of AI applications in endocrinology, although not many actually FDA approved, and most is actually in the diabetes care. If you look into AI for diabetes, we know that there's already diabetic retinopathy screenings. In Singapore, we have it since 2017, and it's already a national program since 2022. We also know that from the earlier talk from Professor Nancy, as well as Professor Sueziani, that a lot of the medical treatment, diabetes treatment, regards to CGM as well as insulin pumps, have already incorporated AI. In addition to that, there are also other systems like health monitoring systems, predictive modeling, right, diabetes management and treatment, public health intervention as well as prevention, and enhancing clinical decision making as well as patient engagement and self-management, which can actually incorporate AI in diabetes care. So let's talk about the role of digital technology in Ramadan, today's change makers. We already know that the guidelines emphasize that it is important to provide a Ramadan-focused fasting education to people with diabetes, healthcare professionals, as well as the public, including community leaders and imams. And we are happy to be able to listen to our imams at the next session. So healthcare professionals and people with diabetes benefited from digital education delivered in various languages throughout Europe, Middle East, and Asia. We also have the DA Global Survey, which had shown that up to about a quarter of type 1 diabetes individuals attend online RFFE, and the proportion is a bit lower for type 2 diabetes at 5%. We also know that with the availability of technology, it has enabled us to conduct more frequent regular webinars for healthcare professionals and public. It has also allowed us to disseminate updated best practices much faster and to a wider network, just like what's happening for this conference. So just if you look at the timeline for DA tools, which has been in existence for a while, we know that DA came about in 2012, right? Through we are fortunate enough that a group of international experts came out at that point of time to actually focus on helping to support our diabetes patients fasting during Ramadan period. At 2018, the DA Safa was initiated with the patient education program, with the app being launched in 2019. available in various languages, although we do have off-app resources such as in Malay, which Dr. Zainuldin has kindly helped us translate and produce. In 2020, there was also the DA Academy app, which as of yesterday has already incorporated the latest risk calculator and guidelines. There's also recorded teachings, past conferences, published articles, and there's also a means for asking experts questions. We also know that through the various conferences every year, there's actually a DA channel that's available for us to actually look through the previous conference recordings through the YouTube. In 2021 onwards, our current Professor Muhammad has again helped initiate the IDF School of Diabetes in Ramadan as an online tool for education. So these are some of the resources that's been available for a while, and it actually helps to provide various outreach areas. When it comes to evidence of digital technology in Ramadan education, we have already, as I mentioned earlier, the IDF School of Diabetes, where there's an online diabetes Ramadan education, which is free, established by the IDF together with DA 2021, currently about 120,000 views and a rating of about 4.5 out of 5, highlighting the value of digital tools. We also have MOOCs that could deliver culturally tailored, high-quality, scalable, and multilingual Ramadan-focused diabetes education to HCPs, as well as people with diabetes. 2 different programs. It was already tested in more than 50 countries with 1,500 users, where about half started a course and about 50% completion rate. The qualitative analysis found that the course is user-friendly and authoritative information, and the HCPs that actually used the program found improved post-MOOC Ramadan awareness associated with diabetes knowledge and ability to assess and advise patients in relation to their diabetes during Ramadan. Of course, this was done by our committed group, Prof. Nisa, Prof. Meher Salma, as well as Prof. Hassani, and the rest of the team, including Dr. Nisa. So telehealth for diabetes Ramadan care. This has been around for a while, even pre-COVID. So one of the earlier studies showing telemonitoring in Ramadan for type 2 diabetes is a useful adjunct for reducing hypoglycemia rates during Ramadan. So this was in 2017, where a small group of about 85 participants, it was found that there is definitely reduced hypoglycemia, lower in the telemonitoring group with an odds ratio of 0.1, and reduced symptomatic hypoglycemia with an odds ratio of about 0.2, as well as a reduction of about 1% HbA1c when it comes to the telemonitoring group compared to the control group. No deterioration in glycemic control. This is our study. Also, it's a very small group, which actually showed improved HbA1c and weight decreased with telemonitoring, in addition to our Ramadan education, which is a group education, multidisciplinary group education, and decrease in complication rates of hypoglycemia post-Ramadan. Another more recent study, type 2 diabetes, was done in Morocco, where it was actually compared pre to get and during COVID period. However, in this study, it was found that with the telehealth education, there was no significant difference between Ramadan pre-COVID and during the COVID period. How about type 1 diabetes? This is done by Prof. Sueziani and team. So it was found that virtual pre-Ramadan visits effectively is an effective alternative to in-person visits when managing type 1 diabetes planning to fast in Ramadan. So this shows that the patients who undergo virtual pre-Ramadan visit were more likely to use CGM than those with no visits. They also showed a least number of fasts were broken for those who had virtual pre-Ramadan visits compared to those who had no visits or in-person visits. And when adjusted for age, the odds of fasting most days of Ramadan were highest in the virtual group at OR of 9.13, followed by the in-person group at 3.0 compared to the no-visit group. So what's in the future for diabetes care in Ramadan? So some considerations that we can take into account. What do we envision as personalized care for diabetes in Ramadan? How can we make fasting not just safer, but as near normalcy as possible during Ramadan period? Where can contribute to be involved in this mission for safer fasting? And what will be the priority, considering the recent advancements in technologies as well as drugs. Could Ramadan intermittent fasting promote remission, as has been alluded previously by Professor Peter Schwartz? So, if you look into this I think it's a narrative review in AI in Diabetes Care in Ramadan, just published about a few months ago by Prof. Salmasha. So, he explored the current and potential roles of AI in diabetes care during Ramadan. We focus on clinical applications, patient outcomes, provider training, and barriers to adoption. So, if you look into this here, you look at the figure on the right, you can see that there's about 1 million studies on diabetes, 300,000 studies on artificial intelligence, 7,000 on diabetes and artificial intelligence, only about 1,008 in Ramadan fasting, diabetes and Ramadan only about 700, Ramadan and artificial intelligence only about 7, but only 5 studies, and probably we have already seen all of them during the conference earlier, and for diabetes, Ramadan, as well as AI together. So taking this into account, it does shows that there's a lot more work to be done with regards to AI in diabetes care in Ramadan. So first, some of the questions that we do need to take into account is what's the role of AI in diabetes care during Ramadan fasting? Which patient populations would benefit most from AI in diabetes management during Ramadan fasting? How do AI interventions differ for type 1 versus type 2 populations? And what are the common side effects of digital health tools in type 1 during Ramadan fasting? Are there cultural or regional differences? What are the provider training needed? As well as who are the healthcare provider groups which require the most targeted training? As well as how do we actually address some of the unique concerns about cultural or religious considerations? And what are the counter attitudes of healthcare providers if we are supposed to implement this into our usual workflow? So there's only 5 studies I mentioned earlier, so we've already gone through most of them in the type 1 talks earlier on. So with regards to AI in type 1 diabetes tools, it's mostly on AID, closed loop. For type 2, it's mostly on predictive analysis and risk calculators. Glycemic benefits, improving timing range to reduce hypo and hyper for type 1 diabetes. For type 2, it's more about risk stratification. For monitoring, it's all about real-time CGM, so feedback for type 1. For type 2, it's more about trend-based CGM interpretation. For type 1, it's more about fasting stability, right? For high risk, type 2 is more about moderate risk and how we can actually help to improve the medication adjustments. There are, of course, barriers with introducing AI applications, and it's always about the cost, especially for the type 1s. And, of course, there's issues about education and technical as well. Whereas for type 2, it's more about the limited accuracy. And, of course, when it comes to talk about AI, again, it's always about training needs. So how are we able to use AI to actually help our healthcare professionals and our patients to understand? So some of the barriers we already know is that there is technical barriers like limited hypoglycemic prediction, clinical barriers like small sample sizes, guideline and familiarity, and we know that when we come to training AI, we do need to make sure that the data is actually well representative of the population that's going to use the AI tool. So cultural, religious issues like technology mistrust, religious autonomy concerns, whether it will be aligned with religious guidelines. Educational issues, low digital literacy, provider training gaps, as well as economic infrastructure issues like cost, lack of reimbursement, and poor internet access and device access. So there are some enablers that can potentially help these issues as well. Okay, I've got 30 seconds. Okay, so some of the knowledge gaps will include these, which are that we do know that there's really limited real-world validation of AI tools during Ramadan, as mentioned earlier. There's also a predictive accuracy, insufficient data, and lack of distinction between general digital tools and AI-specific innovations. Right now, there's still ethical and legal frameworks which are unclear for AI in Ramadan fasting. There's also minimal evaluation of provider training program efficacy, as well as underdeveloped underdeveloped culturally sensitive AI design. So I'm just going to go through another study, which is done by Malta just last month about doctors' perception of AI in managing diabetes during Ramadan. So it's a cross-section study where about 60% were endocrinologists and 70% were actually senior consultants, and only about 60% should receive Ramadan-specific diabetes training. Only about a quarter has training in AI. So if you look into the familiarity of this very senior and experienced group, we do see that the awareness of AI-based technologies is not very high either, right? Most are actually aware of CGM-based AI tools and AID. Bit less were aware of risk calculators and even less machine learning predictive tools. Familiarities with regards to AI-based applications for diabetes care in Ramadan. Similarly, it's more about the AID systems and CGMs. And there are less who are actually aware of AI potential of using AI for decision support systems. How about the perception potential applications of AI in diabetes care during Ramadan period? So we know that it can help to predict hypoglycemia risk, right? It's like especially with the use of CGMs and AID. There's also help with regards to real-time glucose monitoring. They can be used in personalized treatment recommendations, as well as automated insulin dosing, and potentially, especially for healthcare professionals who are not as familiar, potential of use in providing spiritual and religious guidance together with the support of the religious leaders. So how about the attitudes towards AI for diabetes care during Ramadan period? So the couple of areas that we need to consider. Yeah, sure. AI can actually enhance glycemic safety during Ramadan period. So most actually agree or strongly agree with this with regards to whether there's confidence using AI tools to support clinical decisions for fasting patients. Yeah, most actually think that it's either okay. So most actually agree. Most actually agree that it's neutral about that. Patients are receptive to AI-based tools during Ramadan. Similarly, either neutral or agree. There are a bit more concerns with regards to cultural beliefs which may conflict with the use of AI in diabetes care during Ramadan period, and some will either agree or find it neutral with regards to AI-based technologies respecting patient autonomy in fasting decisions. So how about barriers, the perceived barriers at least to AI adoption in diabetes care during Ramadan fasting? So we know that there is, as mentioned earlier, lack of training with regards to AI. There is issues of cost and limited access to technology. Potentially, there may be patient resistance, and that's expected in about a third of the participants, as well as concerns about regulatory concerns, as well as structural religious barriers. So there are a couple of things that potentially can benefit our patients. So the perceived potential will be hypoglycemia, right, with regards to improved glycemic control, patient empowerment, as well as decision support tools. And there's also have experiences with regards to case-specific anecdotes. So some of the things that we can potentially use for AI and has been observed as part of the clinical benefits from AI use in Ramadan. So there are some of this has been quoted. It includes what are the perceived greatest potential benefits of AI in managing diabetes in Ramadan. It includes ensuring safety, personalized care, enhanced patient self-management, real-time monitoring, as well as predictive tools. Concerns and reservations about using AI in this context will include cost, accessibility of AI tools, cultural and religious concerns, and lack of clinical training, as well as fears of over-reliance, and of course, issues with data privacy. And last, what is the suggestions for enhancing AI implementation for diabetes care in Ramadan? Will include, obviously, comprehensive training for both healthcare professionals and patients, improving accessibility and developing culturally sensitive AI tools, as well as integrating this into the healthcare system. So I'm just going to run through this very fast. So as we mentioned, the possibility of personalizing diabetes care in Ramadan for AI. So whether can develop a personalized care plan and how that can actually be used when we use the risk score simulation to actually provide patient with a kind of healthcare plan in how they can optimize their risk profile further. And so these are some of the AI, the ways AI can actually help people with diabetes, and in totality, the use of AI in diabetes care in Ramadan, together with the telemedicine integration, can potentially provide a personalized care which patient can get the comprehensive care within the setting of the home itself, where, during Ramadan period, a lot of our patients are busy with their Ramadan and spiritual needs. And so this is potentially an option that patient can be provided for. So of note, of course, before I end, that there are benefits versus risks for AI in diabetes. And this is correspondence that Prof. Peter Schwartz and Dr. Nohan and team had actually written up. So we do know that with regards to new technologies in their infancy, there could always be unforeseen consequences. And the effect of AI on patients, especially those who are using at a very early age, there could be over-reliance on machine learning and advanced technologies, which in some cases undermine their own independence, self-confidence, and decision-making skills. So there's the IDF AI Technology Committee, which helps to guide this transformation. And together with us, clinicians, frontline healthcare providers, we can provide as the human in the loop to help be the architect for these particular intelligence systems, right? Especially if we use this to provide a kind of program for Ramadan. And this together in a conference like this, where we can actually collaborate, we can prove to have a global impact on how we move the patient's personalized care in Ramadan forward. So just some takeaway points I mentioned earlier about how guidelines still emphasize the importance of our RFFE in the various groups, how we use digital education to actually improve the rates of education, digitalization to help through the online tools, as well as digital tools to contribute to improvising optimal diabetes care and integrating AI in care delivery for Ramadan. So these are my references, acknowledgements. Thank you.